is Danny Barbro, President of AIM Dental Marketing, welcoming you once more to an installment of the Practice Perfection web-based education series. Today's presentation is entitled, Kill 'em, then Oxygenate 'em. Achieve superior patient outcomes with a firm gingival foundation and support future treatment. At least 47% of American adults have periodontitis. The premise of this presentation is that with effective chemical debridement and oxygenation to decrease bacterial loads, combined with scaling, we can significantly reduce this number. Using a prescription tray, patients deliver medication into pockets in short intervals at home between office visits. Research shows that this delivery method, as an adjunct to scaling, leads to more significant pocket depth and bleeding reduction than does scaling alone. As the Managing Director for PerioProtect, Tanya Dunlap, PhD, coordinates clinical research involving prescription tray delivery. In today's presentation, Dr. Dunlap identifies the obstacles and solutions to treatment implementation to help dental teams recognize opportunities for improved patient health. Now, before we hear from Dr. Dunlap, let me remind you that Practice Perfection webcasts run for 90 minutes. While attendees are in listen-only mode, we invite you at any time to submit your questions or comments using the question button on your screen. We will allow time following the presentation to get your questions answered. If we should not get to your question during the webcast, we'll see that they're answered shortly thereafter. Attendance at this presentation entitles you to receive 1 1/2 hours of continuing education credit. Shortly following the webcast, you will be emailed a brief survey with instructions on how to receive your CE. Participants are cautioned about the dangers of incorporating techniques and procedures into their practices if the course has not provided them with adequate clinical experience to allow them to perform it competently. And with that, it is my pleasure to welcome to the Practice Perfection stage, Dr. Tanya Dunlap. Hello, Tanya.
Hello, Danny. Thank you for that warm welcome and the introduction, and good evening, all. I'm so pleased to be with you tonight. I hope to give you some research-based information that has immediate practical application to help your patients and to help your practice. Tonight we're going to talk about challenges that biofilms pose for effective periodontal disease management, and I'll talk about the benefits and limitations of both antibiotic and non-antibiotic-based therapies for biofilm control. But we're going to spend a lot of time on the research behind peroxides and how peroxides can help you better manage what you see on your screen, which is oral biofilm captured by a scanning electron microscope. There are times when you cannot avoid surgery, so we'll review that and what the research shows about that. But basically, as Danny explained in the introduction, this tray delivery is the best home care you can offer patients. You send them home, you ask them to wear the trays in 10 to 15-minute intervals, and it is a good solution because you get them all cleaned up in your office, you send them home, toothbrush, rinse, and floss can't get deep enough to manage what you see on your screen. So most adjunctive care that's offered in dental practices for bacterial infections, for periodontal disease, the infection that's prompting that disease, most of those adjunctive therapies rely on antibiotics. And the problem with antibiotic care is that it's really limited. And it's really limited for a lot of reasons. The first reason is just there's so many different kinds of bacteria in the human mouth that it's really hard for an antibiotic, because conventional antibiotics tend to target specific species. It's very hard for an antibiotic to do this well because there are hundreds of different bacterial species in the human mouth. Over 1,000 have been identified. The typical patient has a couple hundred. And even if you get a good boost from your antibiotic therapy, the biofilms are refractory to the antibiotics over time. For long-term treatment, we need other options. And you begin to understand the magnitude of the problem if you know that in adjacent pockets, you can have very different biofilm compositions. The second reason antibiotics are limited is that the biofilm itself has a basic defense in its own structure. The first line of defense is a physical barrier. It's called a matrix. You're looking at layers, kind of a slime layer of lipopolysaccharides. You've got some exopolysaccharides, some host cells, some proteins in there. But that middle pane where it looks like the cells are enclosed in a bubble, it's drawn on purpose. It is a thick, gooey slime covering that is difficult for antibiotics to penetrate. Most conventional antibiotics don't penetrate it well. There are 3 substances that do penetrate it really effectively, and only 2 you're going to use in the human mouth. Bromine isn't a great matrix penetrator. You're not going to use it. But there are chlorine-based products and peroxide-based products that do a great job getting through the slime so that you can get to the cells themselves. We're going to talk a lot tonight about peroxides. The reason the tray therapy is ideal is because bacteria are constantly moving around in the mouth. You have comprehensive coverage with this tray therapy. In that final stage here on the far right, detachment and dispersal, when a biofilm grows in the human mouth, and it grows really fast, it's warm, it's moist, there's an ample food supply, once it gets to a certain size, it can seed off. So let's say the community gets to a big, and when I'm talking about a biofilm, I'm just talking about a community of bacteria. Let's say the community gets so large that it has outpaced its food supply. It doesn't just die off, it seeds off, either in single cells or in clumps of bacteria enclosed in the slime to start a new colony, another place in the mouth. So you want a tray that can treat the whole arch. And you need this. Patients need this at home because this stuff grows really fast. You send them home after initial therapy or initial prep or periodontal maintenance, and this grows back. This is an image from a scanning electron microscope of biofilm that grew on a carrier. The carrier had been sterile and was inserted into a pocket, glued in place, left there for 48 hours. And Parrish Segazeta is the endodontist at USC who figured out how to glue this thing in there. They left it in for 48 hours, took it out, and the microbiologist, Christophe Chardin, examined it. This grew in 48 hours, completely colonized the carrier. Most offices, when I ask them what's their biggest challenge treating periodontal patients, they'll tell me patient compliance. Case acceptance is second, but number 1, hands down, is patient compliance. So I ask you, what are you asking them to comply with? Because they may not be doing enough, right? They may not be brushing, flossing, 10% of Americans floss or something low like that, rinsing, but none of those techniques get deep enough. None of them get deeper than a 3mm pocket. So you get your patients cleaned up, they may have 3s, 4s, 5s or deeper, and it grows back, and it grows back really fast. So I love this image because you can see how close together all these individual cells are. Now we're talking about single cell organisms, but when they group together in a community, and about 80% of all bacteria in the world are estimated to live in a community, only 20% are free-floating planktonic. When they group together like this in a community, they function like a multicellular organism. It's completely fascinating. There's all kinds of chemical exchanges of information, straight physical exchanges, horizontal gene transfer of information. One of the things that the cells can exchange one to another is antibiotic resistance. That's another reason why antibiotics are not always so effective. And then of course this image is beautiful because of the layering that you see in its 3-dimensionality. So when you have bacteria in a community, on the exterior layers of the community, you tend to have more active cell division. And antibiotics are going to work best. Conventional antibiotics will work best as cells are actively dividing. But the deeper you get into the layers of the community, the less cell division you have. The cells are dormant. They're alive, but they're not actively dividing. Most antibiotics aren't going to work against those dormant layers. So antibiotics are limited. That is not to say that you won't use them. It's just to say that when you use them, they're going to have a limited effect, and they're going to work best on planktonic cells, free-floating single cells that are actively dividing. The 2 times when this is going to be the most effective in your periodontal therapies are going to be immediately after scaling, not 6 weeks later or 4 weeks at the recare visit or the checkup, but immediately after scaling. Because what's happened after scaling is you've removed most of the biofilm. You'll never get rid of all of it. It's just impossible. But you'll remove most of it. And what's left, the cells that remain deep in the pocket, are now exposed. And they want the protection of the community. They're going to begin to regroup and rebuild their community. So at that point, they are actively dividing. That's when an antibiotic is going to work best. Or the second situation in which antibiotics are really effective is if you have an acute inflammatory flare-up, acute inflammatory cycle. Chronic wound care specialists tell us that most acute inflammatory cycles are caused by planktonic cells. Antibiotics would work really well there. Now, Localized antibiotics are an option, so are systemic antibiotics. There are lots of cautions these days for systemic antibiotics. This is an article that was published last year, Journal for the American Dental Association, and they had a fairly low number. I was surprised about it, but they said that 10% of outpatient antibiotic scripts are written by dentists. Now, lest you think that's not very many, that's 25 million scripts that dentists write each year for systemic antibiotics. And in general, not just for dentists, but across the board, all prescribers, up to 50% of all prescribed antibiotics are either not necessary or not optimally prescribed. This is a big concern because we have so many bacteria that are now resistant to antibiotics. And it's not just bacterial resistance you're concerned about, you're also concerned about these adverse drug events. 1 in every 5 ER visits that is an adverse drug event in the United States is for an antibiotic-related adverse event. And the biggest concern is for C. diff. And you know, this is not going to happen very often in dentistry, but it can happen. This article caught my attention right when it came out because of the notion that it happened when a person took an antibiotic for routine dental work, C. diff. The big concern that most patients have is how their bodies are going to respond to these high-powered antibiotics. And the CDC is concerned about that, but really they have an antibiotic stewardship campaign that is in full swing. It has been in place for years. I've been following it since I think 2012. The CDC's big concern, and you can see right here where it's under the problem, they're calling it a public health ticking time bomb. Now, this is one of the earlier pamphlets they put out to try to raise awareness about proper antibiotic stewardship. They've put out several more since then, but at the time, they were calling attention to the potential for bacteria that were completely resistant to antibiotics. Last year, 2016, the first bacterial species was identified by the U.S. military as being completely resistant to all antibiotics. And a couple of weeks ago, it was announced that now there are 16 species. So it's a very big deal. Most of CDC's public health campaign concerns hospitals and hospital care, but for all prescribers, they have a couple of comments, and one is just to make sure that your patients know when you are prescribing antibiotics that they need to take them as prescribed. And two, they're asking prescribers to use and to recommend antibiotics only when they're absolutely necessary, when you don't have another alternative. And there are times, of course, when you need them. But if you have concerns about the efficacy, its limited efficacy for periodontal disease treatment, or any of the side effects, or just wanting to use as little medication as possible, I'm encouraging you to consider hydrogen peroxide tonight. It is an excellent broad-spectrum antimicrobial. It is cleared by the Food and Drug Administration as an oral debriding agent and an oral wound cleanser if it's in a 3% concentration or less. The actual gel you see on your screen is the gel that is going to be presented. This is the drug that has been tested in the 2 clinical trials I'm going to show you, in the big long-term refractory case study, and all the case studies I have for you tonight. It is a 1.7% concentration of hydrogen peroxide as the active ingredient. Now the challenge is how to get it down deep, right? How do you get this deep below the gums? And that's where this prescription tray therapy comes into play. So the Perio tray is the only tray currently on the market that is cleared by the Food and Drug Administration to place medication deep into the periodontal pocket. Research shows it can get up to 9 millimeters deep, whether in the maxillary arch or the mandibular. And the tray itself is unique. It looks more like a mouthguard than a whitening tray, but it's thinner than a mouthguard. It's much more flexible. And what makes it unique is that it has an internal peripheral seal. So for every single tooth, there is a customized seal that is made in accordance with the pocket probing depth chart. And when you have the seal and this extension that fits so precisely added on, you can create a gasket-like environment that prevents the medication from leaking out and then gives you a positive pressure environment to push the medication so deep. So to have a tray made, and the FDA does regulate this tray fabrication process, so the tray has to be fabricated in one of the labs that PerioProtect has trained. There's 5 of them in the United States. And you send to the lab a script, a model or a model or an impression, and you can send digital impressions. and a full mouth probing chart. That full mouth probing chart is important. It will tell the laboratory how to make the tray a seal, and so that information is critical. So let me show you what it can.
One quick question, Tanya.
Sure.
Just, I would, I don't know if I'm correct or not on this. You'll tell me. Are the tolerances as tight as like the typical impressions for actual, restorations that you send to the labs? I'd imagine there's a little more wiggle room there, but I'm not sure. I'm not sure.
You're talking about the quality of the impression, did you say?
The tolerance, just the precision of it.
Yeah, it needs to be very precise. And we ask, usually it's hygienists, usually it's assistants taking this, but sometimes it's docs or hygienists. We ask for 4 millimeters captured of the gingival tissue past the margin. So if they have recession, you're trying to get 4 millimeters even right there at that gingival margin past it.
Okay, so that there is skill. There's definitely a learning curve here to do this right, so that the material does get into the pockets. You need to have I know there's some leakage because we discussed that, but it's a virtually occlusive seal, would you say?
Yeah, so the gel will seep out of the tray if you put too much in it, and really a little goes a very long way in one of these precisely fabricated trays. So it is, it's comfortable for the patient. You want it to be comfortable and flexible. If you first put it in and you see some leakage, then you just want to watch. If it doesn't continue to leak, then you're fine. If it continues to leak, we need to remake it for you. Okay. There is a little bit of a learning curve, as you say, and we offer dental teams a 50% discount on their own trays so they can test it out and kind of practice a little bit. Once you get it, you get it. It's like anything new. You try it out, and we'll work with you. And we do offer all of you who are listening tonight a training option, and that's where we'll go over step by step how to do this.
Sounds to me like the training option would be an important first step then.
It is, yeah, because you want the whole team on board, right? Everybody needs to know. And honestly, the hygienists will run 90% of this program. Docs write the scripts and they supervise. The hygienists run 90% of it. We ask the whole team to participate in the training because I always thought hygienists would deliver trays, but it turns out a lot of times the assistants are delivering trays to the actual patient when the tray comes back from the lab. So it's a good idea if everybody knows what's going on.
Well, sure, they can cross-train, as people come in, but right. It sounds like once they get it, they get it.
Right, exactly. And once you give it a try, it's like anything else you implement in the office. It takes a little bit of organization in the beginning, and then it seems super easy after about a month or two.
Okay, thank you.
You're welcome. All right, so let's look at the two different ways that you can use trays in your periodontal therapies. This is your typical periodontal protocol. Adjunctive LDAs is localized delivery of antimicrobials. Usually that is Arrestin or Atrodox or PerioChip or some other option that you have. Surgery when it's needed, and I'm considering laser therapy like a Lanap or a BioLase, the equivalent of surgery depending on what your patient needs. So the easiest way to implement prescription tray therapy is after debridement and scaling. So this is either a new patient who comes in, you do the initial therapy or the initial prep, and immediately after that, you're going to take impressions for trays, and then you would deliver the trays. They're going to use the trays twice a day for 15 minutes until their next periodontal maintenance appointment. At that next periodontal maintenance appointment, you'll do an evaluation. If they're looking really good, most patients can go down to 1 time a day. If your patient is already long-term maintenance, so think about all of your long-term maintenance patients. A healthy practice has somewhere between 30 and 40% of 4910s, periodontal maintenance. All of those patients are good candidates for trays because almost all of them are struggling between office visits to keep the bleeding and the inflammation under control. And this is what the prescription tray therapy really excels at. But let's take a look. This happens to be a new patient. Walked into Dr. Greg Gist's office. He's outside of Fort Worth, Texas. And I'm going to use VoiceWorks probing tonight. So what you're going to look at, anytime you see these red diamonds, these are bleeding points, and then 4 to 6 millimeter pocketing throughout. Now, in Dr. Gist's office, he routinely does his debridement and scaling first, and then asks patients to wear trays twice a day, and then drops down to 1 time a day as quickly as possible. So 4 rounds of scaling and 2 weeks of tray usage, and you get to hear this March 20 visit, this chart on the right. Patients asked to continue to use tray therapy and come back in 3 months. He comes back in 3 months, and the lower anteriors look good, but the molars don't. That should have resolved. And so the hygienist asked the patient how many times a day he was wearing his trays, and he said, well, I thought I was cured. I'm not really wearing them. And so this is an issue. Patients can be gung-ho at the beginning and they can slack off later. When the bleeding comes back, and it usually does, then you remind them that it was the tray therapy that was working so well. In this case, the hygienist said, we are super excited for the results you've had. We know your lower anteriors feel better. They're, you know, if patients know they're bleeding, usually it's in the anterior region where they can see it. We know the gum tissue is not as tender, but you still have active infections around your molars. And those infections are deeper than toothbrush, rinse, and floss can reach. So can you just wear this tray one time a day for 10 minutes? 10 minutes is good, 15 minutes is better. I will explain that in a few minutes. But Dr. Jist's office, they always go with 10 minutes. They just think it's easier for patients to say yes to. He said, yes, I can do that. And this is what he looks like a year later. Now, you don't always get to 0 bleeding points. And you might fluctuate between 0 and a few, but you want it to get as low as possible. And it really is possible with tray therapy. We expect this. We expect, you know, little to no bleeding. Maintenance patients are the same kind of protocol. This is a patient that had been coming in every 3 months for years. 4 and 5 millimeter pocketing. Again, the red diamonds are bleeding points, kind of scattered bleeding. Not terrible, not great, but she's frustrated. She bought the electric toothbrush the office recommended. She's even flossing, and she can't get any better. So for this patient, it's a good idea to say, I know you're frustrated, and I know you're doing everything we've asked, and it's not your fault. This is a biofilm problem. You got bacteria that are deep below the gums where toothbrush, rinse, and floss can't get. I've got a new option for you. It's a prescription tray. It delivers medication deep under your gums, and the medication will fight the infection that's causing the disease, the localized inflammatory response. In this case, the patient said yes, she wanted to try it. This is what she looks like at her next office visit. So again, you don't get to 0 bleeding. You got here at 14 and 15, you've got a couple bleeding points. Down here, you got a couple bleeding points. This is that same patient a year later. But this is so much improvement. These are good long-term results. How about for somebody like this? He went to several dental offices, and they recommended extracting teeth and placing implants, overdentures even. He did not want that. He's in his 40s. He didn't want to lose his teeth, but he's got some serious disease. 100% bleeding on probing, 4 to 7 millimeter pocketing. He went to a periodontist who's been prescribing trays for 9 years now. And the periodontist, his typical protocol is scaling, tray therapy, surgery when needed. So the periodontist said, no, I don't recommend extracting your teeth. Let's try the scaling and the tray therapy first. So they did that first. And the scaling was completed. So your chart is dated January of 2016. The scaling was completed within 2 months. And then the patient came back, and the periodontist, Bruce Cochran, said, okay, let's get you fitted impressions for these prescription trays. And then the patient said, I don't think I'm going to do this right now. I think I'll just do better brushing and flossing. So they talked about it for a while, but ultimately the patient gets to make the choice. And so the patient left and came back at 3-month recare cycles. In January of 2016, it was better. It wasn't 100% bleeding, but it was still 25% of the sites that were probed that were bleeding. And so at that point, the patient said, okay, I'll try the trays. Trays were delivered in March of 2016, in April of 2016, and you're looking at May of 2016, twice a day for 15 minutes for that month. Now the patient's going to drop down to 1 time a day. So you still have some pockets, 4s, you got a couple 5s. In this case, they did get down to no bleeding at this chart. This is what the patient looks like 3 months after starting on the right. So trays were delivered in April, using them twice a day for 15 minutes for the first month, and then drops down to 1 time a day. This is what we want for your patients. We want that healthy tissue. Now, it is true that teeth will whiten. It's also true, and I'll show you later in the presentation, that you have better plaque control when you use this tray therapy with hydrogen peroxide, because the hydrogen peroxide will work against the biofilm on the tooth surface as well as below the gum line. And it's a nice side effect, no doubt, but what we really are looking for are those healthy gums. Okay, so that's the first protocol. Either right after scaling or in maintenance, twice a day, 15 minutes, drops down to 1 time a day. And do you use these how long? as long as as often as you use your toothbrush every day, basically. Some patients will stop, and if their bleeding comes back, as it does, remind them that they still have this tool, that they were prescribed these trays to be used for optimal gingival health long term. But a lot of patients will stick with it, and they stick with it because of the whiter teeth and the fresher breath. That is the next side effect. Personally, I've been wearing trays for 10 years. I personally love the fresh breath. The whiter teeth are nice. There's no eating or drinking restrictions. It's easy. But the fresh breath is nice too. And for some of your periodontal patients, the ones you can smell before you can see, that freshening of breath, it is one of the first things they'll notice. They'll notice it in 2 or 3 days. It is discernible. And it's a big deal for them. It's also a very big deal for their loved ones. So let's talk about the other protocol. And this is the innovation. The tray itself is an innovation, but the real breakthrough in the PerioProtect approach is being able to use the trays first. And the reason you would use the trays first, even before you do any debridement and scaling, is because you begin to get better control over that inflammatory cycle. And this is a big deal for patients who have any kind of phobic, response to the dentist in general, any kind of dental anxieties, or they have systemic inflammatory conditions. So you're going to get bacteremia even when you chew an apple, right, or brush teeth, but it's bigger when you do scaling. Now, for healthy patients, this is not a big deal. Your body handles the bacteremia from scaling, if you're healthy, in about 90 minutes. But for a patient who is systemically compromised, you've got coronary artery disease, you have type 2 diabetes, you have rheumatoid arthritis, you have some kind of chronic systemic inflammatory condition, the bacteremia that can happen with scaling can be a big deal. And you may want to reduce, it's a good idea, to reduce the bleeding and the inflammation with the prescription tray therapy before debridement and scaling. You'll just have less bacteria entering the bloodstream. You also will be able to do your scaling procedure much more quickly, much more comfortably for the patient. Let me just show you how this works. Here's a patient. He's got Parkinson's disease, and he does have a caregiver who helps, but it is hard to brush somebody's teeth. The treating dentist in this case is Rebecca Hobbs, and she wanted one thing primarily out of the prescription tray therapy: to address the inflammation before scaling so that the scaling procedure would be faster. When you have a patient with Parkinson's disease, you don't know how long they can sit in your chair with their mouth open. So you want that, you want as much time, and you want to use it as efficiently as possible. She also wanted it to be more comfortable for the patient. And let's think, what's uncomfortable? The inflammation is causing the discomfort. If you can get that under control, it's going to be more comfortable for the patient, and the scaling procedure will be faster. It just is. You have better visibility because it's not bleeding all over the place. Let's look, and now you can see what I'm talking about. This is 2 weeks later. Better visibility because it's not bleeding all over the place. You should have better access to. So in this case, the caregiver did need to help. If you have patients who come in regularly with caregivers and they're having a hard time with their oral hygiene, the tray therapy does not replace brushing. It does not replace flossing, but it does make brushing and flossing more effective if you use the tray therapy first. So we do recommend you use the trays first and then brush your teeth after. Again, these results are in 2 weeks. The patient used the tray 4 times a day for 15 minutes. It is hard for patients who work full-time to get 4 times a day, and 3 is still good. But that intense 2-week wearing time really does a great job at getting the inflammation under control. Then you do the scaling, and then you're able to go down to twice a day and eventually 1 time a day. So let me give you an example of a couple of other patients. Manual dexterity issues are a concern, but how about your phobic patients? Here is a patient, 101 bleeding points, porcelain fused to metal crowns. Those are hard margins to keep clean. She was scaled in January of 2014, and she was faithful. She's a good patient. She came in every 3 months, was brushing in between, but not able to keep up. This is giving you an idea of what not able to keep up actually looks like. So it's now January of 2016 when they recommend the first time they recommend that they scale again. And she says no, she refuses. 3 months later, they talk about scaling again. She declined. 3 months later, June 8th, when this chart was taken, they talked to her about prescription trays. And she said yes, she'd try that. So they get her fitted for prescription trays. Trays are delivered on June 23rd. This is 2016. And they ask her to wear them 3 times a day for 15 minutes. She came back in on July 7, so June 23rd to July 7, and she's down to 7 bleeding points. It can happen this fast. This is what the bleeding looked like. And this is where it's not bleeding. Good
Tanya, would
results.
you assume based on these results that she was fully compliant and did
Yes.
it 3 times a day, 15 minutes?
Yes, we would assume that. And one way you can determine compliance, so patients cannot get this hydrogen peroxide gel from just anywhere. They can really only get it from their dentist. We don't sell it.
Reorder.
They have to reorder, and you'll go through a tube, depending on how many teeth they have. You'll go through one tube about, if you're using it 1 time a day, about every 6 weeks. If you're using it 3 times a day, you should go through 1 tube in 2 weeks. So if they come back in and they still have a full tube or a mostly full tube, they haven't been compliant.
Mm-hmm.
But this patient, yes, and it does depend on compliance. There are some patients who are going to refuse it. They're going to say they won't use it, and so don't prescribe it for them. But there are a lot of patients who are especially if they've had deep cleanings in the past or any kind of surgical procedures in the past, or they put a lot of money in their mouth with crowns and implants. They're looking for a solution.
How does it taste?
Oh yeah, the gel. That is one of the biggest, thorniest issues when you're developing a new product. It's a nice mint taste. And so the gel is clear. A lot of practitioners have asked us to put a color in it so you can actually see it better when you lay it down in the tray, because you flip the tray upside down and you put a thin ribbon on the occlusal surface. But we are not going to do that. I'm just telling you right now, we've decided not to do it, because then you have to worry about staining, and you have to go through all the big tests to see if it's going to stain teeth instead of brighten them. And you have to go through a completely new drug acceptance program through FDA. So it's going to stay clear. Yes, yeah. It's going to stay clear.
I think they clearly made the right decision.
Yeah, but it does have a really nice minty taste. If you are allergic to menthols, that could be an issue. We do have a pharmacy that could compound it without the menthol in it. So if you got an allergy, that we can, they can take care of it for you. But it really is available, and it should be, right? You're treating a disease. You want disease management. This is not something that patients should just be able to do over the counter. They can't diagnose their own gum disease. And you want treatment to be followed carefully. You never cure this disease, you just manage it. It needs to be under the supervision of dental professionals. So we just made the choice. We don't sell directly to patients, we only sell to offices. All right, so this patient said, I've had scaling before, I don't want an accepted tray. She's still in periodontal maintenance. She went, again, 3 times a day for 2 weeks and then dropped down to 1 time a day. Here's our poster case. This is a patient in his late 20s, and he is phobic. He's not been to the dentist in years, and he's afraid. And he clearly is not doing enough at home. It doesn't look like he's doing anything at home. And he's in because his breath is so bad. He knows it, and he knows he needs treatment. But he talked to the office. This comes from Craig Buttenmeyer's office in Oklahoma. And he talked to the hygienist there, and he explained that he was afraid. He also was concerned because he didn't have any dental insurance. And importantly, he did not have any paid time off work. So he didn't want to be in the office very frequently. So you could go in and debride that and make your diagnosis and then start with your initial therapy. And most offices will do that. But look at that swollen tissue, 24, 25. You're going to go down and get that. That is going to be a bloody mess. And he may never come back. He is that patient who would come in for one office visit, you do some treatment, reschedule. He's that kind of patient who would never show back up. So they talked to him about using the tray therapy first. Now, the benefit of using the tray therapy first, not only to reduce the inflammation and get the infection under control, but hydrogen peroxide softens calculus. It breaks down the protein chains in the calculus and will modify it and turn it to more like a material alba. So when your patient comes back in after wearing the trays with the hydrogen peroxide for 2 weeks, you should have less inflammation, and that calculus should be really easy to move. If they have like a calculus bridge across several teeth, right, and you make a tray to fit over all of that, and they brush their teeth, you have to warn them that chunks might fall off. It's not their tooth. The calculus gets soft enough that they could actually brush it off. So they talked to him about this. He opted for trays first. They asked him to use the trays 4 times a day for 15 minutes. That was not realistic. He was an outdoor landscaper. It was late March in Oklahoma. He's busy. He's on the job. So set your patients up for success. If they can't do 4 times a day, go for 3. And that's what he did. You want him to come back in about 2 weeks. There's nothing magic about 2 weeks. We know it's long enough from the controlled clinical trials that I will show you on a few more slides. We know 2 weeks is good as a therapeutic duration here. He came in 3 weeks. At that time, at the 3-week visit, they did supragingival debridement, removed all that calculus, and then had him wear the trays for 1 more week. This is what he looks like at week 4. So 3 weeks of trays, supragingival debridement, another week of trays. Look, you're already getting some stippling back. It is going to be so much easier to scale now at the 4-week point. So they did the scaling right after this image was taken. After scaling, you use the trays twice a day. It doesn't matter if you're going to scale quads or sides. As soon as you start your scaling procedures, you can go down to twice a day.
That's an interesting point, Tanya. You're saying that while the standard protocol is to do this in conjunction with scaling, if a patient presents like this, it might make sense to try to just stabilize the terrain a little bit before going in there, because it'll make it easier on the patient.
Right. It'll make it easier on the patient. It'll make it easier on the hygienist too, because the hydrogen peroxide softens it. You know, one of the investors in our company, he invested because his cleanings used to take an hour and a half, and he started with prescription trays, and his maintenance cleanings went down to 45 minutes. So it does matter to patients, and it matters to the. I mean, that's good for your practice too.
Good for everyone.
Right. So this truly is the innovative, and it's out-of-the-box thinking. I get it. I get this totally goes against what you've all have done in the past, and you don't have to do it this way. It's just a really nice option. So trays first, then scaling. As soon as scaling starts, use them twice a day. This is what he looks like 4 months later when he came back in for maintenance. So that's gorgeous. Look at those beautiful white teeth, whiter teeth, but look at that pink stippled tissue. Now, he stalled out in his success. So in this case, he's gotten from here to here in 1 set of trays. Every patient that I have shown you except for this one has done fine with their therapy with 1 set of trays, and that 1 set should last them years. We tell patients on average your perio trays should last about 5 years. This particular patient, because those gingiva are so swollen, because there's so much calculus, the first set of trays really got him far. But he's not out of the woods yet. He went from 100% bleeding on probing to 27%, so that's way higher than we would expect. And his deepest pockets in the posteriors are 4s, and he has 1.5. We could do better than that, especially on the bleeding, if he opted for a 2nd set of trays. He did not opt for a 2nd set of trays. But if you did a 2nd set of trays, the problem with the first set is that the original seals, the internal peripheral seal for the trays that are made for those very swollen gingiva, are now leaking when you have this much healing. It's a good problem to have. I mean, you want the healing to be there. But we would recommend that the patient get a 2nd set. That 2nd set should last him for 5 years. So, hydrogen peroxide. It's your primary antimicrobial, and let's talk about it because it is an awesome option for you. Again, we are recommending a percentage, the active ingredient that's 1.7%, but it's a really nice option because nobody's allergic to it. You don't have to really worry about, with any drug, you're concerned about allergies, but no one is allergic to hydrogen peroxide. We are all making it in our liver. It's in human breast milk. It's in your white blood cells. And as of today, there are no bacteria that build up resistances to peroxide the way they do to antibiotics. So you don't have this concern about bacterial resistance. Now, hydrogen peroxide has 3 broad antimicrobial actions. And the first thing that it can do is cut through the slime. That matrix, again, only chlorine and peroxide-based products are really effective at debriding the matrix. It then will debride bacterial cell walls. It breaks down the protein chains against the bacterial cell wall and lyses the cell wall, and then the cell is dead. And most importantly, it oxygenates the pocket. So this is the most important thing I'm going to tell you tonight. You will kill bacterial cells with every tray application of hydrogen peroxide gel. But that's not the most important part. It is important, but it's not the most important part. What is going to get you this good long-term result is the oxygenation therapy. With oxygen, you're changing the microenvironment of the periodontal pocket.
Yeah, so they pack up and leave, basically.
Yeah, so they do a lot of different things. I mean, the oxygen is really important for a lot of different reasons. So for example, your white blood cells, they need a minimum threshold of oxygen to function. You get deep in a periodontal pocket where that oxygen is depleted, the white blood cells don't work effectively. So by adding the oxygen, what you're doing is creating the right conditions for the body to work more efficiently. You are also putting the gram-negative obligate anaerobes on the defensive. So facultative anaerobes can exist with or without oxygen, but it's those gram-negative obligate anaerobes that are the most virulent. When you oxygenate a pocket, you create an environment in which they can't live very, very well. So you're always putting them on the defensive.
Another quick question I have. I always thought that the biofilm, you know, the actual matrix, the slime were the bacteria themselves. It sounds to me like that is a separate inert substance that just is a vehicle, like plasma or something. Am I correct?
So, yeah, it is. It's like a layering of lipopolysaccharides and exopolysaccharides, some proteins, yeah, some host cells. So it's like this big gooey slime layer. So, and it's a function, or it's a, what do I want to say? It's a part of any biofilm community. So for example, if you think about a dog's water bowl and you see kind of that slime ring around the top where the water has been, that's biofilm, and you got the slime effect right there, right? So yeah, it's something that the bacteria themselves are communicating to produce as a group.
Yeah. It's a medium that they like, but it sounds like the slime in and of itself is harmless. It's what is allowed to propagate within it.
Yeah, so yeah, it provides the space under which the community itself can thrive. It's like a protective layer. Yeah.
Thank you.
Yeah, thank you. So hydrogen peroxide has these amazing properties. It is safe to use hydrogen peroxide products if it's a low concentration every day. And so in the 1980s, when whitening became really popular, the Food and Drug Administration began to study safety of hydrogen peroxide carefully. And they followed patients who used home care products with hydrogen peroxide every day for up to 6 years. And what they noticed was less plaque and gingivitis, which was exciting for them. They did not see any adverse effects, no carcinogenic activity. They saw beneficial effects primarily. And wound healing was enhanced. So they wanted to be able to use hydrogen peroxide to test it out on periodontal patients. But the problem they had was access. It was not easy for patients to get the peroxide products deep under the gums. And so the tray therapy solves that issue. And how do we know this? You got this thing called crevicular fluid flow, right? It flows out of the pocket about at 40 times an hour under healthy conditions. When you get a bacterial infection there, the flow increases. So this is one of the reasons why antimicrobial therapy is tricky with periodontal patients, because that crevicular fluid flow is diluting whatever you put in there. The tray therapy can overcome this. You are able to deliver the medication really deep. And the study that was done that really shows this in a clear way with visuals was done at the University of Southern California, and they followed what's called the biofilm potential technique. And they want to know what's the potential for the biofilm to reform if you change the environment. That was the premise behind it. So you're looking here at a radiograph of the carrier that was glued into 6 and 5 millimeter pockets. And again, Parrish Segazeta was the endodontist who figured out how to glue this. And this was a fairly short study, 17 days of active treatment and then 10 days of inactive. But anytime you see this blue box, this is when the carrier was inserted into the pocket. So 2 days before treatment even began, they put the carriers in the pocket to see what would grow on the carrier. Took it out, started tray therapy. For your first 2 days here, they just used hydrogen peroxide in the tray, quit the tray therapy, insert a new carrier, and what was the potential for the biofilm to recolonize the carrier after the tray therapy is what you're looking at. Then the rationale behind the biofilm potential technique, the actual study itself, the benefit of this design. You can look in, I think it's the August issue of JADA, and I know it's 2009, but I'm pretty sure it's the August issue. So 2 days of tray usage with hydrogen peroxide, nothing, no trays. It comes out, you start your tray therapy again. 5 days of hydrogen peroxide only in the tray. Take the tray out for 2 days, you got a new carrier, and now in these last 2 5-day treatment sections, they used hydrogen peroxide and an antibiotic, a tetracycline. So let's look. Now, this is just 2 days, but you'll note, it's very interesting, this is your pre-treatment. You had a really diverse polymicrobial biofilm, and we don't know exactly what species are in here. You're looking at morphotypes to figure out the kinds of bacteria. So fusiform bacteria and cocci-like are the dominant ones. Cocci tend to be aerobic, fusiform tend to be anaerobic. This is the carrier that was placed after 2 days of treatment with the hydrogen peroxide gel only. Now you'll note you didn't get any bacterial reduction in 2 days, but there was a very dramatic change in the kind of bacteria that colonized the second carrier. They were mostly aerobic at the expense of the anaerobes. In another pocket, again, you got this polymicrobial multi-layered biofilm at the top. That was pre-treatment. This was a 6 millimeter pocket here. Now, in this case, you had a 99% reduction in the actual quantity of the bacteria. Now, the microbiologist, nobody really knows why in the one case you had a change in the composition and not the amount, and in the second one you had a bigger change in the amount. But I will say that by the end of the whole treatment, all pockets tested had a 90% or more reduction in the bacterial load. Later on, I'm getting to the being able to overcome curvicular flow. Later on, when they added tetracycline into the tray with the hydrogen peroxide, when they took those carriers out, they found tetracycline crystals that had grown on the carrier. Remember, the tray therapy ended before the carrier was in place. You have enough tetracycline in there, and if you hold tetracycline at a sufficient concentration for a long enough time, it'll recrystallize, and here it's recrystallizing on the carrier, and even here at the apex of the carrier. So we know that the tray is able to deliver it very deep. And again, the research shows, these are 6 and 5 millimeter pockets, but the research shows that tray therapy has a really nice effect on pockets as deep as 9 millimeters. So now your primary antimicrobial is hydrogen peroxide, and it's important that you can get it deep, but there's another problem that the initial researchers did not identify, and that is time. The duration of treatment matters. You can't irrigate with hydrogen peroxide and get the same results because hydrogen peroxide needs time to do its antimicrobial work. How much time does it need? It really does depend on the concentration, but at this 1.7%, 10 minutes is your therapeutic sweet spot. So you're looking at confocal microscope images from a live dead dye study done at Allegheny Singer Research Institute. This is published in the proof of concept article. And by the way, at the end of this presentation, I'm going to have my email address up. You are welcome to email me and ask me for presentation slides or the bibliography behind this, and I'll be able to send that to you. This particular study at Allegheny Singer Research Institute was done by microbiologists who were testing the ability of several different peroxide products that we had sent them to really get through the matrix, cut through the matrix, and then lyse the cell walls. We wanted to know what was the lowest concentration you could go with, and you want it low because you don't want to cause sensitivities, and the 1.7% is really good about being neutral. It does not cause sensitivities as the higher concentrations do. And we wanted to know what formulation was the best and most stable. You can see their chemical evaluations in the lab, but you really want to see what happens against bacterial cells. So the researchers grew several samples of Streptococcus mutans. Now that seems like a strange species to use because strep mutans are always associated with decay, but they were specifically chosen, and really specifically one strain, UA159, was chosen because that species and strain is known to create the thickest, gooeyest matrix. So they're testing two things. Can the peroxide product get through the matrix effectively, and how long does it take? And then will it then start to work against the actual bacterial cells? So In a live dead dye, you expose the cells to the dyes. If the cell picks up red, the cell wall is lysed and the cell is dead. Red is dead, green is alive, your cell wall is intact. Yellowy orange means it's breaking down. Left-hand side is untreated control. There's no gel. You just want to know what is the normal life cycle of a biofilm. Some cells die, new cells reproduce. Middle image. The hydrogen peroxide gel has been topically applied and held in place for 5 minutes. There's not a lot of difference. 5 minutes is not enough time. But if you leave the gel in place for 10 minutes, you get almost 100% kill rate. 10 minutes is your therapeutic sweet spot. You want your patients to wear this tray with a 1.7% hydrogen peroxide gel if you're using this concentration for 10 minutes. Now, 10 minutes is good, but 15 minutes is better, and here's why. At 10 minutes, you get 10 minutes of oxygen and you get 10 minutes of debridement. But this gel is very different from liquid brown bottle peroxide. There's a lot of differences, but let's just talk. Liquid brown bottle peroxide has this explosive rate of activation. It's this huge burst of oxygen. And if you look at it on a graph, it goes straight up and straight down. Within 3 minutes, the 3% brown bottle peroxide is completely activated and you are down to oxygen and water. The gel is very different. The gel is slow and steady. So for example, if you have a cut on your hand and you pour brown bottle peroxide on it, what does it do? It foams up. If you have a cut on your hand and you put this gel on the cut, it's going to take a lot longer than you expect. I did this, and the first time I did it, I was starting to look for the expiration date on the tube because it was taking so much longer than I expected. And it's not foamy. It is tiny white bubbles that very precisely cover the cut on my hand in this case. But they also stayed bright and white and completely covering the cut for a very, very long time. It takes this gel a little longer than 15 minutes to completely break down to oxygen and water. So what that means for you clinically, if you wear the tray, if your patient wears the tray for 15 minutes, you're getting a more consistent release of the oxygen for the full 15 minutes. Now, if you wear the tray longer than 15 minutes, it doesn't help you and it doesn't hurt you. And
it becomes oxygen and water, basically.
Exactly, right. Your body will absorb both, right. Now, the only problem with that is if you've asked your patient to wear the trays for 15 minutes 2 times a day, if you wear the trays 1 time a day for 30 minutes, it still only counts as 1 treatment. It's not 2. So they need to try to fit it in twice, yeah.
You need to make sure that they understand that, that
right.
It basically shoots its wad at 4 to 15 minutes. So
yeah, right. 15 minutes is it, and it's good. You get 10 minutes. If you're short on time, go for 10 minutes. But if you got 15 minutes, do it. Now, it's important when you deliver trays that you talk to patients about when they can do this, right? What's realistic? If it's a man, does he shave every day? Perfect time. Put the trays in just before you shave, shower, you're done. Women, are they wearing makeup? I don't know how long it takes most women to put makeup on, but 10 minutes is, usually about right. Or taking it off. If you drive to work, take your trays in and out with you, but this is important. Do not leave your trays in a heated environment. So if you're going to wear your trays on the way to work, and it's summer, or you live in Arizona, or Florida, or Texas, at any time of the year, take the trays inside with you. You don't want to leave them in a hot car because heat and hot water can warp the tray material. So you always want your patients to use cold water to clean their trays and leave them in room temperature environment to the extent that you can. But this oxygen is really important. The 15 minutes, the oxygen is so important. And these are just some benefits of topical oxygen therapy. And this information comes from chronic wound care specialists, and we're applying it to the periodontal situation because just think, patients who have these infections that go on and cause this localized inflammatory response that then is a cascade of periodontal disease. You're running a chronic wound care clinic in a sense. These are chronic ulcerations. And oxygen is important to help, especially, and this is actually exciting, if you hold oxygen under pressure. What you will do is stimulate the formation of new blood vessels. In the gingival tissue, we really believe that that beautiful pink stippled tissue is in part from this improvement in neovascularization. The oxygen is just such an amazing, it has such amazing medicinal properties. that this is really why this oxygenation effect of the hydrogen peroxide gel is so important. I already talked a little bit about the macrophage activity, but the benefits of oxygen are important and need to be emphasized, because it's not just killing bacteria. You don't want to sterilize the pocket. You want a healthy bacterial community, and this is what that tray therapy with the hydrogen peroxide gel will get you. Now, there are a lot of hydrogen peroxide products on the market. We recommend that you avoid carbamide peroxides. It used to be called urea peroxide till people figured out what that was. Urea peroxides tend to taste bad, and that decreases use, but more importantly, they irritate the gum tissue. When carbamide or urea peroxide breaks down, it breaks down into oxygen, water, and ammonia, and that ammonia can irritate the tissue. And just for reference, 10% carbamide peroxide, which is your typical low-grade whitening, is 3.3% hydrogen peroxide. So we did test some 3% hydrogen peroxide gel in the tray, and what happened was you had more reports of sensitivity. The 1.7%, you just really don't get very much. When you get 3% or higher, then you can have a lot of sensitivity. It's also true that most carbamide peroxides are fabricated with an oil base, and that can be a problem in this prescription tray, because the oils can warp the tray material. So heat, hot water, and oils, you want to try to keep away from the tray. When it does warp, what will happen is your extension here, instead of fitting nicely and supporting the seal to create that positive pressure environment, it will warp out, it will flip out, and then your medication will all leak out. So you want to avoid oils. All right, so I've shown you some case studies, but what does the research say? Let's look. You're looking at pocket probing depth changes in this particular 6-month controlled clinical trial, and right now we're looking at deep pockets. So for this trial, it was 6 to 10 millimeters are considered deep. PerioProtect makes 2 claims that the researchers wanted to examine in particular. One, that you can wear the trace first, even before scaling. And it's such an out-of-the-box way to think that this is the thing they were really interested in. Does it really have a positive effect, statistically speaking? And the second claim that we make is that this is long-term improvement, because patients are using the trays every day. You're giving them the best home care tool you can when you prescribe these trays. So the gray background is pre-scaling. All subjects for both groups had debridement and scaling here at week 3. And then afterwards is just the follow-up. Now, they go out for 6 months, but note, most people keep up with 3-month perio maintenance when your patients have pockets this deep. In this study, they eliminated the perio maintenance. They wanted to test the claim that these were really long-term results. I recommend you keep up with perio maintenance, but just so you know, there was none in the 6-month trial. So your control group, everybody gets the same toothpaste, toothbrush, oral care instructions, diary. Your control group is just not using trays. The test group, the blue group, is using the prescription trays with the hydrogen peroxide gel only. We're going to talk about 2 other medications you can use in this tray, and there are more than that, but the 3 most common medications I'm going to discuss tonight. But this particular trial had just hydrogen peroxide in the test group. You get almost a 0.5 millimeter improvement in 2 weeks. I'm going to put this into context for you in a minute. It doesn't sound like very much, but it's a very big deal in perio studies to get that kind of improvement over scaling alone, which is your gold standard. After debridement and scaling, that gray-white interface, of course both groups do better because scaling is important. It's just that your tray delivery group is going to do better overall because of the trays. And that is statistically significant at all time points but baseline. Now, what is true of deep pockets is also true for shallow pockets. And this is really exciting news. Everybody wants to put their worst case scenarios on trays to see how well they're going to work when they first get them. And that's great, do it. But most of your perio maintenance patients are struggling with 3s, 4s, 5s, maybe a couple of 6s. They're doing the best they can coming in every 3 or 4 months. You add this tray therapy, you can get into those shallower pockets and still have a really nice effect. It's also true that if you are first seeing the signs and symptoms of periodontal disease, maybe you have a new patient comes in, they've never been told they have periodontal disease, they're mild to moderate, you don't have to wait for those pockets to get really deep to offer some adjunctive care. You can do it right away, and it will deliver into deep and to shallow. The tray will deliver into deep and shallow pockets. So it works in deep, works in shallow. How about bleeding on probing? This is whole mouth, and you're looking at the presence or absence of bleeding, not severity. So if it's bleeding, even a little bit, it's still counted. That is over a 50% reduction in bleeding in the first 2 weeks of tray usage without even doing any mechanical therapy. It gets better. The blue group, they're going to get better after scaling. It's good. About the 3-month mark, they're holding steady at their 50% reduction from baseline, but by 6 months, it's rising. Why? A couple of reasons. They need to do a perio maintenance visit, but it's also true that they've got really deep pockets. When you have 8, 9, 10 millimeter pockets, scaling and tray therapy may not be enough. You may need to add laser therapy or straight conventional surgery. It depends on what each patient needs. But I'm going to get to that in just a moment. How do you know when surgery is needed? I want to just put some of these reductions into context. So you can't put these exactly side by side because you're looking at 3 different studies here. But let's look and see what kind of improvement you got when you added a therapy to scaling versus scaling alone. So all of these measurements on the right are improvements over scaling alone. And this Goodson et al. Is a really nice article, well done. 8 arms to this study, huge study in terms of the number of arms. This is scaling plus tetracycline fibers. You got a 0.3 millimeter reduction for all pockets greater than or equal to 5 millimeters. Scaling with systemic antibiotics, I got you 0.5. Remember, this is about what we got with just tray delivery alone. Systemic antibiotics and tetracycline fibers, 0.4. With surgery and scaling, 0.5, 0.49. Scaling, surgery, and the tetracycline fibers, a little under half. Okay, so the best results they got were scaling, systemic antibiotics, and surgery, 0.82 millimeter improvement on average over scaling alone. When they did all of the therapies, they got the absolute best. Now, in the controlled clinical trials and let me just tell you, in this particular 8-arm study, the results that they got were seen clearly at 6 months and maintained steady out for 2 years. The second to last study was done testing minocycline spheres. It was a 9-month study, and they had a 0.24 millimeter improvement on average when you added the minocycline sphere. To get this, each patient on average had 93 spheres, so 31 per visit. So at the right, when they did scaling, they added 31, 3-month maintenance 31 spheres, 6 months 31. That's a lot. Tray with peroxide, you got, and this number is going to be a little different than the one I just showed you because we are adding 5 millimeter pockets to it, but you get a 0.8 millimeter improvement. So you got to put this into context, but it's good. So the problem is that tray therapy does not solve all your issues. If you have really deep pockets, you may still need surgery. So how do you know? Well, you get what you get at 6 months. If you've been using tray therapy for 6 months and you still have deep pockets, it's not going to get any better. Let's review this data because it is, once you understand these 2 graphs, they're important. This is your control group where they only did scaling and then, of course, toothbrush and floss at home. 7 to 10 millimeter pockets are your green group. In this particular patient population, this arm, scaling did not affect the 7 to 10 millimeter pockets. The percentage of pockets that are 7 to 10 millimeters at baseline are still 7 to 10 millimeters at 6 months. Now, scaling had a really nice effect on the 6 millimeter pockets. A lot of those went to 5s, and some of them went to 4s. This horizontal line here is representing when scaling was done. Now, contrast that with what happens with prescription trays. You add the prescription tray delivery, the hydrogen peroxide gel, and you have a huge reduction in 7 to 10 millimeter pockets. You don't get rid of all of them, but you got a big reduction. 6 millimeters at baseline. Now, a lot of those 6 millimeters went to 5s or 4s or 3s or less even. The tray delivery gave you better results. It just didn't knock out all the deep pockets. So if you've done initial therapy or initial prep, scaling usually, 3 months, the patient's been using the trays for 3 months, they come in, you do periodontal maintenance, 3 more months of tray usage. By that second periodontal maintenance visit, if they still have deep pockets, more tray therapy is not going to help. you need to figure out what's going on. And there are a few reasons why you might not get great tissue response. It could be that the patient's non-compliant, but most people who are paying for perio trays, the national average for a set of trays is like $700, and I've seen it up to $1,200 for a set. Most patients who are paying for this, they're going to be using them in the beginning. But it could be an occlusion issue. If that's the case, then you got to make that kind of an adjustment for patient-specific needs. If it's not those things, and I'll tell you, most hygienists who have experience with this prescription tray therapy, they'll say what they do is at that first maintenance visit, they're going to look for the specific areas that are not responding as well as you want. And in those areas, you want to look for a cracked tooth, an endoperio lesion, or maybe there's still some subgingival calculus there. It could be burnished, hard to find. But if it's none of those things, it's very likely that you need additional you need additional work done. That could be laser therapy, could be just flap surgery. It depends on what your patient's conditions are. But what happens is that the periopathogens can invade the gingival cells. And when that happens, there's nothing you can do topically. You got to go and remove those cells. It's typically that magenta-colored granulomatous tissue. This is most common in deep vertical defects where you have that granulomatous tissue. So you do your laser therapy or you do your surgical procedure, and then you follow with trays. Keep on with the trays, because what happens if you follow your surgical procedures, your LANAP procedures, we have a lot of doctors who offer LANAP who are coming over and also starting to prescribe trays, so you get those really good long-term results. It will maintain your gains. It'll maintain your surgical or your laser gains, and this particular study is giving you some data to support what I'm just saying about maintaining your gains. You are looking at the reduction in bleeding on probing for 66 patients who had all had at least one periodontal surgery. Some had more. There are a couple of patients in here who don't have enough bone for any surgery, so they're contraindicated for surgery. There's just a handful. But they had surgical procedures in the past, and they just couldn't keep up. They're bleeding profusely. Once you add the periodontal tray therapy to their protocols, you got a 50 to 85% reduction in bleeding for your refractory surgical cases. So on average, they were bleeding at 66% of the sites in their mouth when they started at baseline, dropped down by 75% by 6 months, and they were able to maintain that out for up to 5 years. They tracked these patients. Good news, and I didn't tell you this about the controlled clinical trial I just showed you, but good news for both of the controlled clinical trials tonight and this long-term up to 5-year case study is that trays worked equally well for smokers and non-smokers. And we have one outlier here in the test group, but it worked equally well for smokers and non-smokers. This particular group of patients, 66 of them, they were asked to use the trays twice a day for 10 minutes forever. Okay, that's hard to do. I guessed a very low percentage of patients who kept up with twice a day for years. Now, they did self-report, but it actually worked out exactly 50%. 66 of them self-reported that they did it twice a day for 10 minutes, and the other 66% said, the other 50% said they dropped down to 1 time a day. Statistically speaking, there was no difference between the twice a day and once a day users. That data, though, may not tell you the full story, because the treating periodontist said, some of the patients that wanted to drop down to 1 time a day did, and their bleeding came back, and they had to stay at twice a day. So these are refractory surgical cases. These are hardcore cases. Most patients are going to be fine at 1 time a day, but some of your really tricky cases, they might need to stay twice a day to be able to avoid additional surgery or loss of teeth. And when the tooth loss happens and you've placed the implants, then everybody's concerned about implant care. Tray therapy can help with that too. This is a patient who lost his teeth in 2004. Implants were placed in 2006. And he's doing pretty well. This is now June of 2014, and he's not doing so well. And he walked into Dr. Jeffrey Goldstein's office. He lives just east of Philly. And Dr. Goldstein's been a long-time prescriber of these trays, and so he started the patient on tray delivery of hydrogen peroxide gel only, recommended 4 times a day for 15 minutes for the first 2 weeks, and then start the scaling procedure. This patient actually did 4 times a day, came in, and then there were 4 rounds of scaling. As soon as scaling starts, you can drop them down to twice a day. And again, remember, it's 10 minutes minimum, 15 is best. What you're going to look at here on the right-hand side is the charting 3 weeks after the final scaling visit. So 4 rounds of scaling, 4 quads, and now this is the 3-week recare. It's looking better. Patient continues to use trays at home. This is now 3 months later, next maintenance visit. Again, you can't always get to 0. This was a good, in this particular case, they did get down to 0. Now this doc does oral DNA testing. Again, look, your previous tests, your pre-treatment, you'll see here on the top line. Post-treatment, again, I am not claiming that we get rid of all the bacteria. You do not sterilize the pocket. You just change the microenvironment so that you decrease the bacterial load significantly. This is the patient 15 months from start. And this is January of 2016. I did talk to Dr. Goldstein in January of 2017, and he said the patient had 4 bleeding points in January of 2017. So that's pretty good results for a little more than 2 years. All right, hydrogen peroxide. Now the other medication that is commonly used in these trays is doxycycline. And I'm going to have to go a little faster here because I'm running out of time. Vibramycin syrup is the antibiotic that has been tested extensively, and it is recommended not for its antibiotic properties, but it is recommended as an anti-inflammatory agent or for the osteogenic properties that you get with tetracycline, even in the subclinical dose of 3 drops per tray. This is the kind of patient who can benefit from it, comes in every 4 months, has deep pockets, but lots of bleeding, especially around restorations. There's a month difference between these before and after images. She used the hydrogen peroxide and the vibramycin syrup. Vibramycin is a doxycycline in the tetracycline class of drugs for 1 month, and then you discontinue the antibiotic and you just use the hydrogen peroxide. In controlled clinical trials, I'm going to run through this, but I'm happy to send this to you so you can pour over the data carefully. Dark blue group is your doxy group with hydrogen peroxide. Better bleeding results. You just get a boost in the initial phase. It didn't help over long term, but if you want to knock this out in the beginning, you got a hardcore case, you really want fast results, patients love this actually, those fast results, try the doxy. Adding the doxycycline, remember that antibiotics are not very effective on biofilms. Biofilms are refractory to antibiotics. Adding the doxycycline did not help reduce pocket probing depth scores any more than the peroxide alone. It looks like the doxy group did worse. That's not true. There's no statistically significant difference between the 2 blue treatment groups at any time point. And both are statistically significantly better than your control group at all time points but baseline. The point is, the antibiotic is not going to help you reduce pocketing. It only helps you reduce bleeding. There are, of course, contraindications. Patients who are allergic to tetracyclines can't use it. Pregnant and nursing women or children should not use it for concerns of staining. Patients who are taking blood thinners, anticoagulants, specifically Coumadin drug would be like a warfarin drug. Coumadin is a warfarin drug. For those patients, if they're taking those systemic anticoagulants, if they're taking anticoagulants, systemic doses of doxycycline are contraindicated. A few drops applied topically, to my knowledge, has never been refused by a physician, but you should always check with the patient's physician. The benefit of using the doxycycline long-term. For inflammation, it's really short-term usage. For long-term usage, you can help address this, bone loss. And your patient has to be committed to this. This is not fast. It takes a year or more to really see the results. But a patient goes through everything that's needed for an implant. They want to maintain these implants. This one has got pus. It's painful. They started, this comes from Dr. Greg Sawyer, started the patient with systemic metronidazole, oral irrigation, mechanical intervention, even ozone therapy. 4 office visits later, there's still pus. So he gave the patient a choice. You can have surgery. We can do that now, schedule it, or we can try these prescription trays. I can't guarantee either is going to work, but we can try, and we need to do something because so far it's not working. She opted for trays. Within weeks, the infection was completely cleared. No bleeding, no pus, everything's looking good under his microscope. And so he said, okay, so far so good. Keep it up. Keep wearing your trays. 3 years later. Now I'm counting 4 threads on the pre-treatment and 2 threads on the post. What's going on here? We don't expect this in dentistry, right? This is not a laser case. Well, maybe the body's healing itself. If you create the right conditions, the right microenvironment, maybe the body's healing itself. It's very possible. You break a bone in your arm heals. Maybe you can get this in the mouth. But we think that the doxycycline matters. This bone is so dense that it can inhibit orthodontic tooth movement. So you need to know, for your patients who are considering ortho in the future, don't use the doxycycline in the tray. Doxycycline and the tetracycline class of drugs, tetracyclines have been shown to inhibit osteoclasts, which break bone down, and to boost osteoblasts, which help build bone. We think the doxycycline matters. It's hard to tell how much. It's hard to tell how much is the doxy, how much is the body healing itself. But that bone is dense, so we do believe it's the doxy. Let me show you a couple other examples. So you can see the bleeding here, some of the pus. This is a patient from Dr. Gordon Wilson. Dr. Wilson regularly uses Lanap, and this patient came in. He recommended extracting teeth 10 and 14. He was concerned about some others. This patient wanted to keep all of his teeth, including number 10 there. And Dr. Wilson said, listen, you need root canals on 10 and 14. I don't want to do those. I don't want to charge you for those if I don't think we're going to keep them. So here's what we'll do, if you agree. We'll do 9 months of periodontal therapy. That includes Lanap and prescription trays. And then we'll see how we do. If they're looking okay, we'll do the root canals and we'll keep going. Patient said, okay, I want to do it. So the first thing Dr. Wilson did was an occlusal adjustment on 10. Looking decent 9 months later. This is with laser therapy and prescription tray therapy of both the hydrogen peroxide gel and the vibramycin syrup, the doxycycline. There's the root canal. This is September. This is after both root canals were done. 5 years later, everything's looking pretty good. He did lose number 14 though. The root canal was still really infected, despite the fact that the root canal was done. And after this July 2015 chart was taken, they extracted number 14. I want to show you some of these x-rays. Look at this one. And we believe this is a combination of all the treatments, but that includes the tray delivery of the hydrogen peroxide and the doxycycline. Here's one that is not a laser therapy. Now with furcations, I always try to remind myself of this. With furcations, I can't give you any good ideas. Sometimes the furcas respond really nicely, sometimes they don't. Deep vertical defect, healed really nicely, filled in really nicely, found an endodontic infection. They did a root canal and we were able to keep this tooth, which is what the patient's intentions and goals were. Long-term use of doxy, you can get some superficial staining if they have recession. Not the tooth, not the actual enamel tooth surface, but on the root surface, yes, it can happen. So superficial staining, it will come off, but if you're talking to patients about whiter teeth, you want to be careful because if they're using the vibramycin, it could get a light brown rim around them. When you deliver trays, we already talked about this, but when you deliver trays, it is important to help patients remember when they can do it, help them think about it. You need to spend a little time walking them through their day and suggesting times when they can wear it. It'll just help so much. It sounds like it's just such a small thing, but it really does help. Remind them 15 is best, 10 is if you're on a short time constraint. What happens if they need future restorative work? Composites, amalgams, inlays, onlays, almost all of that is fine with the original tray. Crowns, 80% of the time the original tray works well. New trays are definitely going to be needed if you have to do a bridge, an implant, or an extraction. And sometimes what happens is you get this gingival foundation all cleared up. This is a maintenance patient every 4 months. Start with tray therapy, get it all cleared up. 2 months later, you've got a couple crowns added. You get that firm gingival foundation. Patients believe in what's going on in your dentistry. They add the crowns. This is again 8 months later. And you don't always get to 0, but they did here. Other good patient candidates, anybody who's a heavy plaque producer, or you're concerned about root caries. Periodontists really started this use of trays. Anybody who has sensitivity, a lot of your maintenance patients are starting with sensitivity. They're great candidates for trays with fluoride. If you're already prescribing them for long-term periodontal use, skip the hydrogen peroxide one day and do a fluoride treatment 3 times 20 minutes. I'll go over that in just a second. Anybody who wants to whiten their teeth and their teeth have been too sensitive to the higher concentrations of peroxide. A lot of doctors have prescribed the trays for whitening. It was never any of our intentions at PerioProtect, but it is what they do. So the good news is that the tray delivery of hydrogen peroxide alone helps reduce the plaque. The blue and the green group are your tray delivery group, and you get better plaque reduction just from the hydrogen peroxide. They combined it with toothbrushing for all groups, but you just got, it makes your toothbrushing more effective. So brush your teeth after you use your trays. Now, if you have caries, you're concerned about caries. Maybe your patient is a high caries risk, or they're, some people are just really high plaque producers, or they have xerostomia, and you're trying to help them figure out how to handle that. If you're already delivering the trays for periodontal reasons, use fluoride. And the other time is for chronic sensitivity. Your maintenance patients who are only chewing on one side of their mouth or avoiding ice cream, this is what you do for caries, or if you're concerned about root caries. 1 20-minute application 1 time a week would be the most frequent you do it. And when you do it, when you use fluoride in the tray, you only use fluoride, nothing else, just the fluoride. Periodontists were the first to do this for their folks who they were concerned about root caries with all that recession. So they have been using 20-minute application once a week. Chronic sensitivity, don't do any hydrogen peroxide for a day and do 3 20-minute applications. It is possible to completely wipe out the sensitivity. 3 20-minute applications. The tray is going to deliver whatever you put in that tray deep, and the fluoride will help for sensitivity. And of course, whitening. Now this patient was a refractory surgical case. His gums, he's 68 years old, right? Those are like teenage gums. We're excited about that. But everybody likes his whitening. It will whiten your teeth. No eating or drinking restrictions. Let's talk about costs. 2 perio trays, they cost in the lab, and again, you do have to use one of the FDA cleared laboratories, $175 plus shipping would be your cost. And then most offices charge around $700, but I have seen it for as high as $1,200 a set. There is an insurance code. If you elect to take our training, we're going to go through all of this really, really carefully with you. But you've got some options here, and it really does, you're not just helping your practice, your patients, you're helping your practice too. If you do the national average at $700, this is the kind of revenue opportunity you have. Depending on how many hygienists you have in the practice, you can do a lot of good straight out of your hygiene chair. Let's look at what a couple of practices did. This is one practice who's in the middle of Kansas, very small town. In 2 years, they had prescribed 203 trays. They charged $375 a tray. So they were averaging new revenue a little more than $3,000 a month consistently for 24 months. This is a practice in Michigan, larger practice. I think there are three hygienists full-time in this practice. They did more trays, but $6,200 extra a month out of the hygiene chair for 22 months is a nice boost. Offices that do really well with PerioProtect, get together and do your team training. It's important to think about which patients are going to benefit. Anybody who is a halitosis case, anybody in periodontal maintenance, anybody who's afraid, anybody who you have prescribed or treatment plan for scaling and they never showed up, refractory surgical cases, high plaque and you're concerned about caries. They're all good patient candidates. And we have help for you. We've got brochures and everything that that are designed to help patients understand this. So if you decide you want to start prescribing trays, you go through our training program, we will personalize it for you. We recommend you track your patients, make sure that you know which ones are your prescription tray patients because they can only get their gel from you. We talked about this earlier. A pop-up is nice. It helps you remember to ask if they need more gel because sometimes patients forget. I highly recommend that you do some kind of tracking system and put a tray point person in charge of calling your patients. There was an office in Louisville, Kentucky that rocked out the system. And so I called to find out what they were doing, and they did everything you would expect, except I didn't expect this. And it's really simple. It was just a spreadsheet, and they called patients within the first week or 2 of taking home trays. And the patients responded so well to that. They really appreciated it. And it gives you a chance to find out if they really understood the delivery instructions at the delivery visit. So I want to encourage you that there are a lot of benefits to prescription tray therapy. You're going to get better results, just hands down. We've been doing this for a long time. Prescription trays have been on the market since 2005. Long track record, good research results. It is true that your patients have to be willing to do this. But as I say, a lot of patients are looking for a good solution and it whitens their teeth, and it freshens their breath. Everybody wins here. Hygienists who have been working with patients in prescription trays for years say that their prescription tray patients stick with it better. They understand what they're doing, they don't skip as many appointments, and of course the hygienists appreciate this because their job is easier and faster. And all you guys have is a training fee, and we're going to give you a discount here, which I'll explain in just a moment. I want to encourage you that your patients are going to like this. So I was the research liaison before I became the managing director at PerioProtect, and I sweated over this data more than anything else. So I got the clinical trial data the same day the independent statistician did. Over 40 patients were in this particular clinical trial. Over 40 patients were using perio trays in this particular clinical trial, and they all had to give an exit survey about the use of the trays. And so there was unanimous agreement on all of these categories. Easy to use, little to no sensitivity, comfortable, convenient, whiter teeth, fresher breath. But look, it's a scaled agreement. The strongest you can agree is 10, and the last point, would recommend perio trays to others, got a 9.3. Patients like the prescription tray option, and I am confident that yours will too. Confident enough that we're willing to give it a try, even at a discount here. This personalized training, it's a 90-minute training that you schedule according to your convenience. We have a few trainers. I am one of them. Another colleague in our office here is Kelsey, but we will meet you via GoToMeeting, the day and time of your choosing. 90 minutes is ideal. If you've got 60, we can cram it in, but it doesn't work as well usually. And you will walk away from that training ready to start. You can start immediately. We'll find out what your current protocols are, what your biggest challenges are, and we'll tailor the presentation for you. So you do get a $40 discount. If you are interested in the training, if you want a bibliography of the research I've talked about tonight, or if you want a sample of the slides, be sure to email me. That is my email address right there, and you can reach me at the office. At this office, we try to stop everything we do when you guys call. You're hard to get to. You're busy with patients. When you call us, we'll try and stop everything. If I'm not available, one of my colleagues would be really happy to help you. And I just want to thank you right now for your time tonight to learn more about this. Danny, I'll turn it over to you.
Thank you very much, Tanya. We want to thank you. I appreciate you sharing the PerioProtect methodology as well as the generous offer. And I think it's pretty clear that it would be a steep, that is fast learning curve. As you just said, probably after 90 minutes, I think most people are ready to go, but you've made it clear that you're available should anyone have any questions or concerns while they're implementing this protocol in their practice. And the fact that you came from the research side first is I think it really helps fuel your belief and it obviously demonstrates your expertise, passion, and commitment to the whole process.
Well, thank you for that.
Yeah, and at the end of the day, it's what the patients perceive, and I think that one of the last slides showing that's very important to share. That especially that last one, the patients would recommend it to people. You don't get much higher scores than that in the high 9s, so that's really impressive. Let's jump in. We don't have a lot of time. We have a lot of questions, but as I promised, if we don't get to them, I will share these with Tanya, and she'll follow up with all of you individually. One question, just in no particular order, do you ever recommend trays for patients who have chronic decay?
Yes, I will tell you that some docs really do this on a regular basis. They might treat particular patient populations. We've got some dentists who work specifically with special needs patients or chronic some patients who are taking a lot of medications and they have xerostomia, or patients who have been treated for radiation. And they all, in all of these cases, they're using the hydrogen peroxide gel in this prescription tray to help deal with concerns about decay.
Very good. What do you do you talked about patient sensitivity, but let's move on. Do you have any research comparing tray therapy to LANAP and I'm not even sure what LAPT is, laser-assisted periodontal therapy?
So not head-to-head, no. We do not. So the head-to-head clinical trials, the two of them that I discussed tonight, went head-to-head with scaling, or scaling plus the prescription tray therapy. In the last 2 years, we have seen a resurgence in doctors who offer laser therapy, and they've been doing it for a while, and this is what I hear really routinely. You get great cases with laser. You get good cases with laser, and you get some not so good cases with laser. So when you add the prescription tray therapy after the laser is completed, or some docs even do it before and then after, you get consistently better results, and that's what everybody wants.
Speaking before and after, what about before implants? Do you recommend treatment before, and if so, for how long before the procedure?
Well, you would want to do it long enough and if there was any infection there, that it was cleared up. And this is an area that's really ripe for research in terms of bone strength, right? Making that bone so that it can maintain the implant. But I would say how long you use the trays before the implant is placed really will depend on the patient condition, how serious is the infection, a minimum of 2 weeks.
Okay. Can other medications be applied in the tray?
So tonight we talked about hydrogen peroxide, the doxycycline, and fluoride. If you have disquamative gingivitis like in planus, there's a periodontist out in Oklahoma who really pioneered this. He uses a lidocaine gel in the tray to make it more comfortable, then the hydrogen peroxide to clean it up and to oxygenate it, and then Lidex. And these are those patients who, their gum tissue is just like sloughing off. Nothing else was working, so he tried this. He said this works consistently well. Sometimes you start with Lidex, he does, because it's readily available. He said sometimes he's got to change the topical steroid if the patient's not responding as well to Lidex, but he's had really good success with us. So that would be another indication. Again, we haven't tested it, but I do know he's treated maybe 15 patients that way.
I see. All right, our last question that we have time for, not our last question, but why don't antibiotics work on biofilm long term?
So the problem with antibiotic therapy is that it's typically restricted to 7 to 10 days, or if it's that time-released capsule 21. The bacteria resist biofilms in several ways. They can build up resistances and teach them to other cells. They are difficult to access because they're covered by the slime. It's difficult to get the antibiotic there because they're covered by the slime, and the antibiotic can't get through that very easily. But also there's a lot of bacteria that are just dormant, and most antibiotics aren't going to work against that. If it does work well, and it can, antibiotic therapy can work well. You can have a really nice positive boost. But what happens after you stop the antibiotic therapy? Typically, the biofilms form back, and it could be quickly or it could take a while. But it's hard for people to brush and floss with proper technique, to do it the right amount of time, and even if they do, it can't get deep enough, the brushing and flossing, or the rinsing. So adding the tray therapy is just, it's just the best home care you can offer patients.
All right, on that note, we're going to have to close the questions. I just want to conclude by reminding everybody that in a couple of days you'll receive an email with instructions on how to receive your 1.5 hours of CE credit. And I want now to invite you to please mark your calendars for our next webcast, which will be on Thursday, April 27th at 6:30 p.m. Central Time, when our special guest will be Dr. Rob Barrick. And you're not going to want to miss this. He's got an amazing technology, and the topic of his presentation will be referrals are the lifeblood of your practice, uniting GPs and specialists to increase income by improving outcomes. Until then, this is Danny Bobrow, thanking you for your continued commitment to practice perfection, and thanking you once again, Tanya, for your commitment to the health of patients everywhere.
It was a pleasure to be with you. I appreciate this opportunity.
You're welcome, and goodbye, everybody.